Hello, my name is Samir, and my poster is about the use of a neurostimulation technology called TDCS, particularly how it could be useful for treating depression in our rural settings. So I want to start by talking about neurostimulation, what neurostimulation is. So neurostimulation is the use of a device to electrically stimulate the brain with the goal of achieving some sort of therapeutic effect. I'm sure everyone is familiar with ECT or electroconvulsive therapy, which is used in psychiatry for refractory cases of depression, psychosis, all sorts of indications, and it's essentially inducing a controlled seizure under anesthesia for therapeutic purposes. There's also a technology called transcranial magnetic stimulation, or TMS, that uses a changing magnetic field to produce action potentials in a targeted area of the cortex, um, particularly the area of the prefrontal cortex called the DLPFC, or the dorsolateral prefrontal cortex. So I'm going to get a little bit into the weeds of why that area is targeted. It might be helpful for those who are interested in understanding. Um, but fMRI studies were essentially done on a slew of depressed patients. fMRI is functional MRI, shows the activity of different brain regions. And they showed that overall, correlatively, the DLPFC, this particular area of the dominant prefrontal cortex, usually the left, tends to be underactive in depressed patients, lacking blood flow, essentially. Um, could be the cause, could be the effect of the depressive state. But because of that, because this TMS can stimulate the uh, superficial cortex, and because this area was identified, TMS, not ECT, not what I'm talking about, not TDCS, TMS, transcranial magnetic stimulation, is used to stimulate that area, and the goal is to achieve a therapeutic effect in depression. And meta-analyses have shown that uh, it's an effective intervention uh, versus placebo. So while that is the case, while it is effective and much less invasive than ECT, it's sometimes cost prohibitive because of insurance reasons, and oftentimes, especially rural West Virginia, there's just simply not a location to go to receive this therapy. It's also very time intensive. So it's like some protocols are 30 minutes a day for a whole month essentially. So if that's a long driving distance to these sites, it's just not feasible for many of the patients in rural areas such as rural West Virginia. So that brings me to talk about this technology, TDCS, which stands for transcranial direct current stimulation. Essentially uses two electrodes, an anode and a cathode, that you place on the scalp transcranially. And a direct current DC goes between the anode and the cathode, and a small amount of that current across the electrodes reaches the brain tissue and has an effect. So a main difference between uh, the first let me talk about the evidence for this intervention. So I did a poster on TDCS my first year, and back then, the evidence was kind of a mixed bag. But there were plenty of meta-analyses even back then showing that this was most probably an effective intervention compared to placebo. But October of 2024 and last year, there was a nice, large, well-powered, multi-site, well-powered, well-randomized trial published in Nature, um, that showed essentially a European TDCS product um, uh, was pretty efficacious in comparison to placebo and sham, which is essentially like a procedural placebo, um, for providing relief from depressive symptoms. So that was a great kind of a new development in the TDCS space. So uh, the meta-analyses, these recent RCTs, it's probably an effective intervention compared to placebo. And now I'm going to talk a bit more about its mechanism of action and why it may be more beneficial for certain patients versus other patients, and how to, maybe if you're interested in psychiatry or primary care, to guide what patients may benefit from this intervention. So I mentioned that area that TMS targets, the DLPFC, dorsolateral prefrontal cortex. So TDCS, what I'm talking about, targets the same area. And I forgot to mention this earlier, but the reason why TDCS is better suited for these rural environments than TMS is TMS requires this large, expensive chair, like I mentioned, whereas TDCS, it's the devices that can meet the criteria for like a clinically validated protocol. They can be under $100, very small, textbook phone size, and powered by 9-volt battery, so much more accessible in that sense. And if you place the anode and the cathode correctly, you can use the technology to target that same region of interest, the dorsolateral prefrontal cortex. But in a comparison, important difference in comparison to ECT and TMS, a TDCS, this device, does not directly induce action potentials. It alters the resting membrane potential and hence the cortical excitability to a relevant level. In other words, it makes action potentials easier to happen, but it doesn't make them happen. And because of that, there's some evidence, and I think this will be more will come out in the next couple of years, that if you use the part of the brain essentially that is being stimulated, this DLPFC, while the stimulation is applied, it'll increase the magnitude of the effect, and that has something to do with the mechanism of long-term potentiation, which is the neural mechanism that it makes synapses stronger. I'm not going to get into the weeds of that because I could talk about it for a long time, and I'm sure you don't want to hear that. But it's cool stuff. So I'm going to get a little bit into to finish off the neuroscience of depression from like a functional neuroscience standpoint, the little that we know, and I'll try to simplify it. So there's a sort of a model of depression that I subscribe to that kind of helps conceptualize how to use some of these treatments and how they might be effective. In this model that was kind of created through the use of fMRI and resting fMRI studies, they've shown that certain areas of the brain tend to fire together when we're doing certain things, and those are referred to as neural networks, functional neural networks. Two important functional neural networks are the default mode network, which tends to be active when we're sort of at rest doing nothing or reacting to internal stimuli sometimes. And in the context of depression, it's very involved in depressive rumination. And then we have the frontoparietal network, is what a lot of people call it, central executive network, some people call it, which is involved in attending to external stimuli and involved in doing tasks, is another way to think about it. So these two networks, they are inversely correlated. So when default mode network goes off, frontoparietal network goes on, and vice versa. So they both turn each other off. And yeah, so in depressed patients, essentially, a lot of depressed patients, one more important thing is that DLPFC is a central node of the frontoparietal networks. So in depressed patients, these task-oriented networks tend to be chronically under-exercised due to social isolation, rumination, etc., to the point where they have trouble switching from default mode network to frontal networks, and they have trouble, when they do switch, maintaining activity in the frontal networks. So the idea behind stimulating these frontal regions of their is basically to artificially exercise these parts of the brain in order to allow the patient to engage more easily with the external environment. And the reason I bring this up, and the reason I think it's important for patient selection in terms of utilizing this technology, is these neurostimulation modalities, TMS and TDCS, but also ECT, to be completely honest, tend to work best for underactivated patients. So very remarkable psychomotor slowing, melancholic, have trouble getting out of bed, have trouble maintaining conversation. A question I used to like to ask patients is, can you pay attention to your favorite TV show? If the answer is no, it would be a very good candidate for TMS and ECT specifically. But TDCS, unfortunately, is better suited for a bit milder symptoms in comparison to TMS and ECT, because for the reason that it cannot force the action potentials. It does not directly cause the action potentials, but it just makes them easier to happen. But because of its mechanism of action, how it affects LTP, I won't get into the weeds of it, but it's more effective if you get the patient to engage in a task that activates these frontoparietal networks at high frequency while they're undergoing the stimulation. So the best way to utilize this technology is to have the patient wear the headset for 30 minutes, 3 to 5 times a week, while they actively engage in something that is positive and externally engaging. And if the patient cannot do that, then they might not be the best suited candidate for TDCS therapy specifically. So an example would be, you had the patient wears a headset while being engaged in a positive, happy conversation with those around them, or while watching a television show that evokes, that they can stay engaged with, that evokes positive emotions. Playing a video game that evokes positive emotions are examples of tasks that can be done while wearing this headset. So yeah, I hope that was interesting, and I kind of threw this together because I was hoping that if anyone is interested in psychiatry or primary care would consider utilizing this maybe in their practice. And because of this recent RCT, there's going to be FDA approved TDCS device coming out in the U.S. in the next from Flow TDCS in the next year and a half, and there'll be plenty of people piggybacking off that, because the way device approval works in the US is the first device has to prove efficacy and safety. The trial to prove efficacy is very capital intensive, meaning it requires a lot of money because there are so many people that you have to have in order to prove the efficacy. But the devices that come after that, after the first device is FDA approved, the following devices just need to prove the safety of the device and the equivalency to the first device, which is much less capital intensive. So what ends up happening is, after this first device comes out with this sort of landmark RCT, is a bunch of devices will piggyback off of them, and they'll flood the market. So that'll bring costs down. But the question you have to ask yourself as a clinician is, how equivalent is this device really? And I just want to say TDCS specifically is a very remarkably simple technology, to be completely honest with you. And as long as it's safe, and the electrodes are being placed in certain locations, I wouldn't worry too much about the devices being piggybacking devices being dissimilar enough to the point that they would have a clinically different effect or lack of efficacy in comparison. So yeah, I hope you found this interesting, and thank you very much for your attention.